Good evening, everybody. Respected President Sam, Dr. Avinash Bhosle sir, Vice President Sam, Dr. Vikas Karne sir, the Sam's newsletter editor, Dr. Shilpa Tivaskar madam, today's esteemed chairperson, Dr. Amla Kudalkar madam, Professor and Head, GS Medical College and KEM Mumbai, then Dr. Mansingh Adnaik, a renowned minimal access and bariatric surgeon from Kolhapur. Today's invited faculty, Dr. Vaishali Chalgaonkar madam, Professor and Head, Department of Anesthesiology, IGMC Nagpur, and Dr. Naresh Paliwal. He is a Professor Emeritus, PDMC Amravati. Then MMC Observer, Dr. Vijay Panse sir, and all national GCs, SAMS advisory members, GC member SAMS, presidents and secretary of various city branches, and dear ISNs. A warm greetings from SAMS. On behalf of SAM and Society of Anesthesiologists Satara and Surgical Society, I welcome you all in the SAMS curriculum, that is Anesthesia for Laparoscopy, What's New. We will start the webinar with the prayer.
Okay, Sheetal, we can't hear the prayer. You proceed.
Okay, taking blessings from Ma Saraswati and the divine light, now I invite our president to deliver his welcome address.
Yes, good evening, everyone. I welcome chairperson, speakers, delegates for this today's webinar. Laparoscopy surgery is a rapidly evolving and expanding field and has become the standard of care for a variety of procedures, offering many benefits and improved outcome. High-risk patients like cardiac and pulmonary diseases posted for laparoscopy surgery present a unique challenges for the anesthesiology. With the innovation of both laparoscopy surgery and anesthesia, the standard procedure has been critically examined and many other anesthetic options are now we are taking like lumbar spinal, segmental spinal anesthesia. And this anesthesia has now become an established and widely used technique now. So whether the patient should be intubated or not, whether we should use the different local or regional block, actually no anesthesia technique is superior to or inferior, safe or unsafe, or with or without medical legal hassle. The anesthetist has to choose as per patient's condition, available resources, own skill and confidence. Ultimate aim is to keep the patient safe and surgeon comfortable for performing surgery. Having more ornament in our bag is always helpful. Whether we do, we should be able to justify, and in case some complication occurs, should be in position to treat it without getting much worried about ultimate outcome. So, listen and interact with our well-known speakers and experts. So, I am looking forward a great session ahead. Thank you very much. Over to Sheetal.
Thank you, sir. Next. Taking this opportunity, I would like to request kindly register for our SAMSCon, which is going to be held at Pachkani this year. Next. Today we are honored to have our MMC observer, Dr. Vijay Kanse. He is a well-known surgeon from Karat. He is a professor and head of the Department of Surgery, KIMS Karat, and medical director, Krishna Charitable Hospital, Karat. Welcome, sir.
Thank you, madam. Thank you, madam. I have joined.
Okay. Thank you, sir.
I'm happy to introduce him as he is husband of our Kanse ma'am.
Yes, sir.
With HOD at Krishna Medical College. So we'll have another chairperson as a surgeon for this session, I think.
Yes.
Okay.
Yes.
Welcome, sir.
Yes, thank you, madam.
Next, now I request our Vice President, Dr. Vikas Karne sir, to introduce both our chairs.
Thank you, Sheetal Madam. Good evening to everyone, and welcome to another interesting webinar by SAMS. And we are honored to have two esteemed personalities as our chairperson for today's session. Dr. Amla Kudarkar Madam. Madam is professor and head in GS Medical College and KM Hospital, Mumbai, and a very renowned teacher. Madam is known for establishing dedicated pain OT in Sion and KM Hospital, and also anesthesia ICU and skill lab in KM Hospital. Madam was organizing secretary of ISACON Maharashtra in 2025 at Mumbai, and she also received a President Appreciation Award in ISACON Maharashtra. Welcome, Madam. I also take this opportunity to welcome Dr. Man Singh Adnaik. Sir is MBBS, DNB General Surgery from Lilavati Hospital, and FNB Minimal Access Surgery from Global Hospital, Hyderabad. Sir is working as a consultant Minimal Access Surgery and Bariatric Surgery at Rainbow Hospital, Kolhapur, and he is interested in minimal access hepatobiliary surgeries, bariatric surgeries, and and minimally access colorectal surgery. So we look forward to you, Madam and Sir, for your expert opinion, and we look forward to your suggestions and inputs during the discussions. Welcome everyone, and over to you, Sheetal Madam.
Thank you, sir. Now I request Dr. Shilpa Tivaskar ma'am to introduce both our faculty.
Yeah, it's immense pleasure to introduce the great teacher, Dr. Vaishali Shergaonkar Madam. Madam is Professor and HOD Department of Anesthesia, Indira Gandhi Government Medical College, Nagpur. Madam expertises in thoracoscopic procedures and difficult airway management and other procedures. Madam is the awardee of Best Medical Teacher Award by Director of Medical Education, Government of Maharashtra in 2018. We welcome you, Madam. Our next speaker is none other than Dr. Naresh Paliwal, sir. Sir is Professor Emeritus at Dr. Punjab Rao Deshmukh Memorial Medical College, Amravati, India, and sir is pioneer of thoracic segmental spinal anesthesia. We welcome you, sir.
Thank you, Dr. Shilpa. Now I request Dr. Shergaonkar madam to proceed for her deliberation.
I hope my screen is visible.
Yes, ma'am.
Yeah. Respected President SAMS, Dr. Avinash Bhosle, Honorary Secretary, dear Sheetal, dear Shilpa, and all office bearers of SAMS, as well as faculty from all over Maharashtra. I'm really indebted to have me as a faculty for this session, which is one of my, a topic very close to my heart. And it's not only the presentation which I would be giving today, but I would like to share my experience of last 17 years doing laparoscopic procedures, almost 9,500 laparoscopic procedure which we have conducted at our tertiary referral center. So warm regards from Indira Gandhi Government Medical College, Nagpur. As you all know, that laparoscopic procedures are now dictum procedures. The patients are aware about the laparoscopic technique, and so they demand laparoscopic surgery. Naturally, we as anesthesiologists has to be well versed with the various techniques of anesthesia for laparoscopic procedure, as it is now almost a need of the hour. So why we need to do such kind of webinars regarding laparoscopic procedure? Because it poses a unique physiological challenge for anesthesiologists. The transition from an open cavity to a pressurized carbon dioxide filled cavity needs to have an balance of ventilation strategies, hemodynamic monitoring, and proactive pain management. Though the pain may be less as compared to open procedure, but definitely we have to look for pain management also. So on this background, let's take a deep dive into the clinical pillars of laparoscopic anesthesia. So this a unique title which I have suggested air, care, and repair. Why this? What are the pillars? I would describe this title in these three categories. Air means airway management, carbon dioxide insufflation physiology, and ventilation. This part would be a part related to air. Care is intraoperative, or I would say perioperative management, and hemodynamics during the procedure. And repair would be complications, rescue, and recovery. So these are the three concepts on which I would present my lecture today. The outline is pneumoperitoneum physiology, positioning, its effect, preoperative assessment and optimization, airway management, the current concept of ERAS, which was up till now for only open type of procedure. Now it is applicable to laparoscopic procedure also. Intraoperative management, post-operative care, post-operative elements of ERAS protocol, and let's discuss some of the complication on case-based scenarios, and a quick reference matrix, which can be a small SOP type of things which we all use, and with special consideration and take-home messages. So let's start with CO2 physiology. CO2 is one of the commonest insufflating gas which we are using, and it is being used worldwide. So what happens when we insufflate the cavity with CO2? There are two types of effect. One is volume effect and one is pressure effects. Means how much volume we are instilling and how much pressure it's being insufflated. So the average pressure range should be 8 to 15 mmHg depending upon the structure of the patient, age of the patient, and the need of the surgery. But it should be started from, ideally the book says it should be started from 1 liter per minute. But you all know our surgeons will not allow so gradual start of insufflation. So at least it should be started from 5 liters per minute and gradually increased to around 12, which is the safe. But an average range would be 18 to 15 mmHg, in which the physiology may not affect much. But standard book says that with even 5 mmHg of intra-abdominal pressure, the physiology starts altering. So what does happen? What does it leads to? Initially, increase in systemic vascular resistance, initially increase in mean arterial pressure. This is the effect of volume as well as pressure on the sympathetic system and sudden release of catecholamines. As the intra-abdominal pressure increases, there is gradual fall in cardiac output because of IVC compression, reduced venous return, and then the BP may start falling. Vagal bradycardia on sudden insufflation is one of the common things which can happen during the procedure if the surgeon is a novice surgeon who tends to insufflate the cavity very fast with large volume as well as pressure, and we have to monitor the CO2 insufflator also. In respiratory system, there is increase in PaCO2, which again starts with 5 mmHg pressure of intra-abdominal pressure. There is diaphragm splinting, so FRC would decrease, increase in peak airway pressure, VQ mismatch, and with a prolonged type of surgery, atelectasis would be there. With all this, the primary thing is cardiac output, which reduces. There can be decrease in renal blood flow, neurohormonal changes. Gradually, it can lead to increased ICP if the position is head down for a long time, and bowel ischemia can also happen. So these are the things which can happen with insufflation. With 20 mmHg of pressure, we should get alarmed because this is a pressure which can hamper the physiology at most. And when the insufflation is continuous, there is absorption of CO2 from the peritoneal surface, and the rate of which is 30 to 50 ml per minute. So these are the physiological changes which we can monitor with a simple checklist, and it can be followed like insufflation, during insufflation, and target IAP. So let us confirm the position of patient, whether Riles tube is put or not, bladder catheterized, monitoring is properly active and it's being stable after the induction. Baseline vitals should be documented. Muscle relaxation should be confirmed, because in obese patient, the muscle relaxation, if not given proper, the cavity may be tight and the surgeon tends to increase the intra-abdominal pressure abruptly. So this has to be confirmed. Ventilator setting should be adequate, like 6 ml per kg of tidal volume, PEEP of around 5, respiratory rate of 14. And one should not forget checking the insufflator device also. Once we are stable with all these kind of parameters, we should allow surgeon to insufflate. During insufflation, confirm that Vary's needle is in proper position, which usually our surgeons colleague do. Start with low flow, like less than almost 1 liter. We have to watch for early complication, that is sudden EtCO2 fall, because this complication occurs at the start of insufflation, can occur at the start of insufflation itself, as well as vasovagal, that is bradycardia. Continue monitoring the trend of EtCO2, hemodynamic responses, and again I would say insufflator reading should be monitored. As you achieve the target of intra-abdominal pressure, adjust the ventilation according to the PCO2 or EtCO2 value. We need to have recruitment maneuver intermittently, document all the baseline changes and the changes which has occurred after that. So also temperature monitoring and fluid status. So these are the basic during the setup of any laparoscopic procedure. There can be changes because of the surgical position, maybe a head down, which is usually used for colorectal surgery or gynec surgery like hysterectomy, which again lead to decrease in venous return, and increase cardiac output. Diaphragm may be pushed, cephalad may have an we may have an ET tube migration. So after insufflation, if it is in head down position, auscultation, bilateral auscultation is must, so that we can confirm that our tube is in proper place, because invariably right-sided translocation of tube can be there. Key care, that is pressure points, should be secured. In surgeries in which reverse Stendenberg position is given, like upper GI surgery or maybe bariatric surgery, it is somewhat good for us in respect to respiratory system, as that excursion of diaphragm is better, but again decrease in venous return can be there. So key care points is watch for profound hypotension and deep venous pooling, so that if there is fall in BP, we have to feel the venous bed with some amount of extra fluid. Lateral decubitus position, which are usually used for nephrectomies or adrenalectomies, they don't have as such much compromise. Only thing is VQ mismatch, which can be managed by ventilation strategies. Post-operatively, the dependent lung may get atelectasis, and so also the pressure points. So we have to take care of pressure points in all three types of positions. Now, up till now, the laparoscopic surgery was confined to routine surgeries in fit patient, but day by day it is being used in high-risk patient, like patient who are having cardiac compromise or even respiratory compromise. So we ought to know the status of the patient very meticulously before giving fitness for such kind of procedure. Severe COPD asthma patients, they are prone to have an CO2 retention. If there is a fall in cardiac output and BP is low for a prolonged time, naturally the CO2 homeostasis is hampered. So it would be difficult to eliminate CO2. In that situation, the patient may become a tank source of CO2, which is already there in asthmatic patient. So again, the point of care is we have to manage the respiration accordingly. So also cardiac dysfunction. Patients who are having left ventricular hypertrophy, already low ejection fraction, these patients, their cardiac output may be dependent on the rate, and if the rate is heart rate is not maintained, then the cardiac output would decrease and the left ventricular output, that is stroke volume, may reduce. So we have to have an proper monitoring during intraoperative period, which has to be planned during preoperative assessment only. So also morbid obese patient, they are already having reduced FRC and they are at risk of aspiration. So preoperative care is important. Preoperative optimization is important. Secondly, raised ICP patient having previous any head injuries or any tumors, maybe glaucoma patients, they are again a special zone patients who may have problem. So let get them optimized in the preoperative period. Coagulopathy, pregnancy, and previous abdominal surgery, such history has to be obtained because they may lead to certain problems intraoperatively. A preoperative checklist suggests, as for any general anesthesia, 6 hours of solid and 2 hours of clear fluid for the nil by mouth status. Prokinetics can be used as well as H2 receptor antagonists in the patients who are having GERD. Airway assessment has to be meticulous, specifically during the bariatric procedure or patients who are already having the BMI more than 35 or maybe more than 45, for more than 40. Cardiac parameters, if it is a cardiac compromised patient, don't be so courteous for not doing echo, because it is one of the thing which can guide you in a preoperative period whether to go for a laparoscopic procedure, and if it is a low ejection fraction, we can go for a low gas type, low insufflation pressure and low insufflation volume for those patients. Beta blockers, antihypertensive, whatever patient is taking should be continued. Respiratory parameters, PFT, can be obtained in a preoperative period, as well as bronchodilators, and chest physiotherapy can be advised. Medications, if patients on anticoagulant, it can be bridge. Consent should be taken as it is again in high risk patient, maybe a high risk procedure anesthesia also, and of course the conversion to open surgery should be obtained. Patient should be counseled for the type of anesthesia which we are using. Investigation, as the protocol suggests, depending upon the surgery as well as the criticalness of the patient, we should go for a complete array of surgery which we follow normally. Now, how to secure an airway? In a simple surgeries like appendix, cholecystectomy, which are low risk surgery in patients less than 30 BMI, second generation supraglottic devices can be used with proper monitoring of oropharyngeal seal pressure. LMA Procil, RMA Supreme can be used, but through which we can allow gastric drainage as the channel is present. GERD, obesity, long procedures, we should go for an endotracheal tube. LMA, there are less hemodynamic response at insertion as well as at removal. So the decreased chances of throat soreness or coughing on emergence. But again, it is the choice of anesthesiologists what to do and how acquainted the person is for putting those kind of supraglottic devices. Otherwise, endotracheal tube is a gold standard. It can be used in obese patient as well as the high-risk patient who are having the risk of aspiration. Rapid sequence induction can be done. Secure, auscultate. Be aware of the arrhythmias and laryngoscopy response that can be tackled with drugs. The ventilation strategy is 6 to 8 ml, but nowadays it is said that go for 6 ml only per kg. It is considered as a lung protective type of ventilation, PEEP, rate around 12 to 16, which can be maneuvered intraoperatively to keep a target ETCO2 of 35 to 40. IE ratio should be 1:2. Intraoperative monitoring, as our standard monitoring ECG SpO2, NIBP, TCO2 is mandatory. So also keep a temperature record and urine output for prolonged type of surgeries like long colorectal cancer surgeries, or maybe nephrectomy or adrenalectomy. For that also we should go for temperature as well as urine output monitoring. In complex procedure, it is mandatory to have arterial line, because we need to have a beat-to-beat monitoring of the patient. Major fluid shift, if expected, we can go for CVP, and in high-risk patient, transesophageal echocardiography is also suggested. Obese patient, in which we have to ensure that full relaxation is there. So 10 of 4 monitoring is advisable. If we are using TIVA for management, we can go for BIS or entropy. Induction, usually propofol is a safe drug. If hemodynamically unstable, we can go for ketamine, or in high-risk patient, even etomidate can be used. Maintenance is usually by inhalational anesthetic agent, sevoflurane, desflurane, whichever is available. Even isoflurane can be used. TIVA is preferred in some cases as it reduces the chances of post-operative nausea, vomiting. Muscle relaxation, again depending upon the availability, atracurium, vecuronium or rocuronium. If the airway is normal, we can induce the patient on rocuronium also and maintain the patient on rocuronium. Analgesia, usually fentanyl propofol is a combination of induction, so it can act as a good analgesic. Supportive, we can give paracetamol or local infiltration at the ports. Antiemetics, ondansetron, dexamethasone, it should be given. Now, what does ERAS protocol says? It is enhanced recovery after surgery. So we are also the main component or main persons to have a unique role during ERAS. This reduces the stay of patient by 30 to 50%. Reduction in complication rate is also there, and compliance needed from patient side is also there. So let us, nowadays it is promoted more that we should go for, if the laparoscopy is like a daycare procedure like appendix or even cholecystectomy, then ERAS is definitely comfortable. Preoperative assessment as usual. Fasting can be reduced. We can prescribe carbohydrate loading. Plan of anesthetic, either TIVA or volatile anesthetic agent, wherever desflurane is available, the results are very good. And opioid sparing plan should be discussed. In this type of surgery, avoidance of opioid is helpful because it helps to have an early recovery, a clear-headed recovery, as well as incidence of post-operative nausea, vomiting is less. The main hindrance for patients to go home is the incidence of nausea, vomiting. The patient is also not comfortable, and naturally we cannot discharge the patient. So it has to be avoided. Intraoperatively, all type of monitoring is mandatory, as we have to ensure patient safety. Fluid management is slightly restricted, or it can be a goal-directed fluid therapy, because over zealous fluid therapy can lead to the gut can be swollen and paralytic ileus can be there. So better avoid overzealous fluid therapy. Normothermia to be maintained, and anti-emesis prophylaxis can be dual, giving ondansetron plus dexamethasone. So minimize the use of opioids. We can use some adjunct like supportive blocks. Encourage the patient to remove all the bags at the earliest, so that patient can be back free, as well as patient can be monitor free at the earliest. So these are again the protocols of ERAS, which we have already discussed: counseling of the patient as well as patient education, preoperative fasting to be limited, avoid routine bowel preparation for the colorectal surgery, because that can again lead to the bowel dehydration in some cases, and to avoid that, if we give overzealous fluid therapy, bowel edema would be there. Prehabilitation like smoking cessation, alcohol cessation, anemia correction, and nutritional support. Pre-medication benzodiazepines are to be avoided. If at all we need to give, because for anxiolysis, it can be a low dose simple midazolam. And wherever indicated, thromboprophylaxis should be given. Anesthetic plan slightly modified depending upon the plan of surgery or the intricacy of the surgery. Other parts remain same, like consent and high risk information to the patient. Anesthesia plan is usually general anesthesia, maybe TIVA with propofol remifentanil combination, which is really excellent in smaller, in the surgeries like appendix or even bariatric surgery, gastric banding or such type of surgery. The volatile anesthetic agent like desflurane can be used, and the recovery is really good. Goal directed fluid therapy, multimodal analgesia with blocks or NSAIDs combination is helpful. Normothermia to be maintained and avoid all stress responses. Nowadays, even laparoscopic hernia repair are being done, and it is the patients are demanding for that. So what is this? Tape tap. Is it same like our routine laparoscopic procedure? No, there are slight differences. Tape is a total extraperitoneal repair of hernia in which preperitoneal space is being insufflated with CO2. That space is less, and the absorption of CO2 as it happens from the peritoneal cavity is delayed from the extraperitoneal or preperitoneal space. So the operative field is restricted for the patient, and the amount of CO2 as well as the pressure to be used has to be meticulously planned. Otherwise, there can be means the peritoneum can be or the CO2 can leak into peritoneum during the insufflation itself. In TAP, that is transabdominal preperitoneal repair, it is direct preperitoneal view. So higher pneumoperitoneum can be there in this type of procedure. In TAP, the chances of surgical emphysema are very high. So we have to again modulate a bit in this type of procedure. Again, depending upon the patient's condition, maybe hernia patients are slightly in the geriatric age group. So we have to do pre-anesthesia evaluation as per the condition of the patient, ASA category of the patient. Preperitoneal absorption is preperitoneal CO2 absorption may be faster initially, but plateau is reached late. So the risk of surgical emphysema is also there. Peritoneal tear can happen, and being a limited space, poor relaxation is experienced by surgeon. So they may tend to increase the pressure or insufflation volume. As such, hemodynamic effect are slightly less as compared to the peritoneal insufflation. In TAP, the specific issues will be the effect like pneumoperitoneum are nearly similar to the peritoneal insufflation. Bladder injury risk is high. Iliac vessels are in proximity, so the chances of damage or injury to these vessels are there. And mesh fixation is difficult if the tacker is being used. So it the implication is that pain threshold for this patient, pain management has to be meticulous. So port site, they may use 10 mm port. So risk of incisional hernia or hematoma around the ports can be there. So these are the issues with hernia repair. Now post-operative recovery, for that PONV prophylaxis has to be given as per AFL score. I will not go in much details of this score, but ondansetron alone or ondansetron plus dexamethasone, like a dual therapy, if required, if the incidence is too high, we can go for a triple therapy in which rescue metoclopramide or droperidol can be added. Pain management, port site infiltration is very common. So also in procedures like laparoscopic cholecystectomy, the gallbladder bed can be instilled with local anesthetic, IV paracetamol, ketorolac, or other NSAIDs can be used. And shoulder tip pain. So if there is the EtCO2 is persistently high, or the duration of insufflation is high and absorption is continuous, then the patient may have an irritation, subdiaphragmatic irritation leading to shoulder pain. In this type of procedure, patient may get irritated due to the pain of shoulder, so which has to be managed. Even we can use a instillation of local anesthetic around phrenic nerve. Emergence and extubation has to be on table. Neostigmine glycopyrrolate is a combination, but Sugamadex can be used in the bariatric procedure. Awake extubation is preferred in obese patient. After proper oropharyngeal suction, and if any kind of dye is injected via Ryle's tube or feeding tube, we have to ensure that the dye is absorbed or it is being sucked properly before extubating the patient. Because whenever during bariatric surgery they are removing the nasogastric tube, the dye may get accumulate into the oral cavity, and if we are not sucking that oral cavity before deflating the cuff or our ET tube, there can be salient absorption of that dye, which can lead to irritable type of pneumonitis in postoperative period. So oropharyngeal suctioning has to be meticulous. ERA's protocol says that in a postoperative period, there should be early oral feeding depending upon the procedure which is done, early mobilization. Patient should be free of drains and catheters, and postoperative analgesia should be a regular type of analgesia rather than giving only only tackling the breakthrough pains. Adjuncts can be used like wound infiltration, tab blocks, or in some patients, even epidural plus general anesthesia is a good choice so that postoperatively patient is comfortable. Now let's go for an intraoperative complications. I would discuss this in some of the scenario-based complications. One life-threatening complication is gas embolism. So the incidence is less, but the mortality is bit high. So we should be very cautious. The mechanism is CO2 which enters through the vascular system, either by direct injury to any vessels or during insufflation. It can form a gas lock in right ventricle, which reduces the cardiac output and cardiovascular collapse. So sudden fall in EtCO2 and sudden collapse, one should get alert that probably it can be a gas embolism. There can be a millville murmur which is heard. Signs like pulmonary hypertension, CVP rises and initially and then suddenly fall. So what to do? Stop insufflation, flood the field with fluid, give 100% oxygen, place the patients in Durant position, aspirate the gas if we have an CVP line, and if arrest occurs, early and fast CPR. Other complications can be subcutaneous emphysema, which is during insertion of trocar, or if the trocar get displaced during that, this can happen with novices surgeon. Crepitus can be there. So there is persistent rise in EtCO2. We can manage this with the help of proper ventilation, and if it is too tight, then release incisions can be given to release those gas. Pneumothorax or pneumomediastinum is again one of the complications. This usually happens during the procedure like hiatus hernia repair, or maybe myotomies, or if there is any diaphragmatic hernia in the patient. Other visceral injuries like vascular injuries. I have an experience in one case. It was a simple appendix case, but overzealous pressure put on the Varies needle during insertion. It was a direct IVC which got injured and patient collapsed. So these are simple things, but at the time of trocar insertion itself, we have to be very alert. Let us go for this scenario. A 42-year female patient posted for laparoscopic cholecystectomy. 40 minutes the surgery was there, and then there were sudden changes in monitors. EtCO2 started falling, SpO2 gradually fall, heart rate increase, BP was suddenly low. So what was the diagnosis? Probably sudden fall in EtCO2 could have led to any kind of embolism. So as we discussed previously, we should immediately stop insufflation, make the patient supine, and the resuscitation should start as per the condition of the patient. If we usually don't put CVP line in cholecystectomy patients, but if at all it is there, we can aspirate the air by advancing the catheter in Durant's position. Another scenario is 58-year male posted for laparoscopic Nissen's fundoplication, and the surgery was smooth till 55 minutes. Then suddenly surgeon reports there is difficulty with dissection near diaphragm. The anesthetist was monitoring the ventilator monitor, which shows sudden rise in peak airway pressure, heart rate increase, SpO2 started falling. And the back, when the patients were ventilated manually, the bag was very tight. So it was nothing but a tension pneumothorax. A drain was put, insufflation was start, drain was put. At that time, there was endobronchial intubation, so it was tube was withdrawn. So the checklist suggests that what is the management algorithm? It suggests that first you have to check the ET tube, then ask the patient to deflate pneumoperitoneum, check the airway pressures, check that the placement of tube is proper. If increased pressure persists and BP is falling, then you can ask the surgeon to put an intercostal drain into second intercostal space, and then definitive procedure can be done. Involve thoracic surgeon if the diaphragmatic rent is big. So these are certain management algorithms which has to be done fast without waiting for each and every step, and it checking each and every step. The certain checklist, it has to be simultaneous. So the Pearl says that if CO2 can dissect through diaphragmatic cura, definitely tension pneumothorax is without thoracic injury. So always consider monitoring peak airway pressure in laparoscopic surgery, specifically when the surgeon is working around diaphragm. The third case, it's in case of robotic APR. Stripped Enlenberg position was given. 3 hours surgery, anesthetist notes progressive monitor changes, which is 72 mmHg progressive rise in EtCO2, and which was initially 38 and now it's almost 72. EtCO2 was also high. When ABG was done, it was an 85 mmHg of PaCO2 value, which suggests a severe hypercarbia and severe respiratory acidosis on ABG also. Saturation remained low and it never touched 100% in spite of proper ventilation. So causes would be definitely hypercarbia. The subcutaneous absorption of CO2 can lead to this trocar displacement, extraperitoneal insufflation. At the same time, hypoventilation, if we do, it can lead to hypercarbia. So ventilation strategy has to be meticulous. Rebreathing can occur. We have to check for any circuit malfunction or circuit disconnection. Exhausted soda lime will guide that probably the CO2 absorption is not proper, and metabolic symptoms like sepsis can occur in a late period. Now, if the patient is already having COPD and the PaCO2 value preoperatively is high, we have to go for a permissive hypercarbia. So that's why in a preoperative evaluation, even ABG is important to know the preoperative baseline value of PaCO2. Ventilation strategy has to be adjusted. We can increase the rate till 22 per minute or even 26 per minute. Reduce PEEP temporarily if the peak airway pressure is very high. Brief desufflation of EtCO2 can help in this situation. ABG is a quick guide for us, and in extreme situation, we can request the surgeon to go for an open procedure. Subcutaneous emphysema can be recognized by palpating over abdomen. Even it can lead to face engorgement, and the neck can be thick or engorged neck with a severe type of subcutaneous emphysema. So in this situation, again, go for an release incision and proper ventilation strategy. Then go for the another case, which is a sudden bradycardia on trocar insertion, which I have already discussed, that this overzealous insufflation of CO2 can lead to sudden pressure and volume effect, which will lead to rapid peritoneal stretch. This can occur if the relaxation, muscle relaxation is not proper. CO2 or sudden bowel manipulation is done at the time when the patient may not be under proper depth of anesthesia. So heart rate drop, BP fall precipitously, patient can land up into even cardiac arrest. So in this situation, again asked to stop insufflation, go for atropine. If at all arrest is there, we should go for an CPR. Major vascular injury, which we have experienced once in our OT, it was a stable patient and sudden drop in BP, sudden increase in heart rate, sudden drop in BP, low EtCO2, which was maintained. And the color itself of the periphery color change, and there was no circulation as if in a lower limb. So this such kind of picture was there, and which suggests major vascular, either arterial or venous injury, and it leads to hemoperitoneume type of thing, which has to be meticulously managed with the help of vascular surgeon. So in this situation, we should not go for an laparoscopy try. Immediately can ask the surgeon to convert to open, and we can take help of the vascular surgeon at this point of time. During the bariatric procedure, there are situations that we feel that probably intubation is easy for this patient, but sometimes we may land up into CICO type of situation. So during bariatric procedure, let us follow the DAS guidelines and algorithm as suggested by DAS guidelines, and be prepared for a difficult airway card and also a surgical cricothyroidotomy. One pearl I can suggest that during preoperative evaluation itself, we should scan the neck by USG so that we are aware how much thick pad of fat is there in the neck region, and if at all we need to go for in front of neck axis, how easy or difficult it would be. So we can take help of our ENT surgeon, but be prepared for plan A, plan B, plan C, and also D in during laparoscopic or during bariatric surgery in obese patient. Or it may not be a bariatric surgery, but other incidental surgery in obese patient. So this is a simple algorithm, trigger sign, what actions to be done, what drugs to be kept ready, and what are the take-home messages. So this can be kept in our OT, fixed in our OT, so that around the clock we can see and we would be prepared to tackle the complications which can happen during laparoscopic procedures. The special situations are laparoscopy during pregnancy. Usual preferred time is second trimester. Left lateral tilt to be given. Limit the intra-abdominal pressure to 10, maximum up to 12. CO2 effect on fetus are there in long term. Target maternal EtCO2 should be in the range of 32 to 34, and fetal heart rate monitoring should also be done. During robotic surgery, stripped and lumbar positions for extended duration of time, so high intra-abdominal pressure is there. We need to monitor even intraocular pressure and facial edema in this type of patients. They may lead to longer extubation time, considering delayed extubation in such type of patients. So plan for an post-operative post-anesthesia care unit or even in ICU should be kept ready. Pediatric laparoscopy, the position matters, but the intra-abdominal pressure is very important. Such thing can happen that a previous day or a previous case is an adult laparoscopy in which the surgeon has set the CO2 insufflator to a pressure of about 12 to 15 mmHg and a flow of about 10 to 12 liters per minute. And second case, a pediatric case is taken and the insufflation is with the same thing which has been set for an adult patient. In this situation, there can be sudden bradycardia and even arrest in pediatric patient. So these are also special situation in which we should be careful. So what are the take-home things? EtCO2 drop, consider gas embolism. Lung protective ventilation is important during laparoscopic surgery. Multimodal analgesia with the help of either drugs or a combination of local blocks with IV agents or with NSAIDs. TIVA for high-risk patients who are prone for postoperative nausea vomiting. Confirm the neuromuscular blocker is reversed properly and adequately, and we should keep a plan for conversion to open surgeries. So this is what from my side. I would say that the best anesthetist is one who anticipate before the crisis is there and not during it. Thank you.
Thank you, madam. Now I request both chairperson for the.
Thank you very
Dr.
much,
Vaishali, madam.
ma'am. We'll have a very small discussion after this because we want to complete one another lecture also. So, okay. So please, sir.
Can I make few comments?
Yes, ma'am.
Yeah. Hi. Hello, Vaishali madam. Very nice and in-depth lecture. I mean, you covered almost everything. So few just comments that now that the awareness about the laparoscopic surgery has increased, even the patients are demanding, and we have to be ready for laparoscopic surgeries in, for more invasive patients, surgeries, more difficult patients, and in extremes of position. So we have to gear up for that. About ERAS, the preoperative carbohydrate load that you said, usually they suggest maltodextrose, any complex carbohydrate. But what we have been using is API. That becomes very
Yes.
cheap.
Yes,
Appy,
we are
one
also
appy in
using
the
that
night
in
and
some
one
of
in the
our
morning.
patients.
Yeah.
Yeah.
So that we give. Then again, pre-operative, then of course, prehabilitation is a part of it. During induction, it is not opioid complete no to opioids, but we give fentanyl at induction. And then induction is usually with propofol and rocuronium. What is important is maintenance. We have to avoid nitrous oxide.
Yes.
Rather than stopping it later on when you are suspecting gas embolism, it is better to avoid nitrous oxide. So it is oxygen and air that we give. The initial insufflation is at the rate of 2 to 4 liters, and still, since there are many surgeons attending this, I take this opportunity to request them that it is always better to go slow. Whenever there is a problem, either the respiratory system or cardiovascular system is at risk, it is better to maintain a lower abdominal pressure. And what I have seen here is the idea of creating pneumoperitoneum is for better visibility. And that can be done by, lifting the abdominal wall with either hooks or something like, something that
This is called as
opens
the
up.
lapro lift
And
technique.
then you can have abdo lift. So you can have better visualization. So you can have the same conditions at the cost of lower intra-abdominal pressure that we have seen. Third is, once you are inside, you can instill lignocaine on the lower surface of the under surface of the diaphragm. That will also help. In addition to the port site injection, that also helps. Then rest, what ours is teaching hospitals with multiple students. So many thesis topics are usually taking place. So OST, that is oblique subcostal tab block, is another method of analgesia which I found very useful. Whenever you are using remifentanil, you said we have to be ready for immediately post-operatively a long-term analgesic. So what we have been doing is oxygen, air, and then maintenance on dexmedetomidine and desflurane. So that works because it is hardly 1 hour surgery, and one of these analgesics are in place. So post-op recovery is good. While considering an obese patient or any patient for a prolonged head-eye position, say you are giving bariatric surgery or any hiatus hernia surgery, because there is pooling of blood in the lower extremities and muscle relaxation, it is always better to give not pharmacological but mechanical prophylaxis against DVT. Because sometimes introp means whatever low molecular weight heparin you may not be able to give that time, but you should give mechanical
mechanical pump or pulse device can be attached.
Yeah.
Even the
And
stockings.
while ventilating, it is better to use, keep a pressure. If you use volume limited ventilation, it is better to use PCV-VG if your ventilator has that possible. So that way you can keep a pressure, limit on the pressure that is achieved. So these are few points I thought. And while you are working in the place where hiatus is there for hiatus hernia or any esophageal, the arrhythmias are very common because of the proximity of, so that you will have to keep a watch on.
I'm probably, am I audible?
Yes.
Yes, sir, you are also
very well.
Yes, sir. Yes, sir.
So I'm on the other side of your curtain. So probably the odd man out here. But quick, Dr. Vaishali, it was a very descriptive, lucid presentation. You have covered all the major points. Just a few points. Position in the OT has to be given only after insufflation has been achieved, and you have to wait for few minutes before you give the position so that the cardiac IVC compression is actually compensated for. Second, if you have if you are doing it under LMA, So don't, it should be a snugly fitting LMA so it doesn't get dislodged. Otherwise, it happens that there is only one size available and you're trying to do a female, male, and even pediatric patient along with that LMA. So you should keep all the LMA sizes available that are there. For hernia, you specifically mentioned about emphysema. Always after surgery of hernia, specifically TEP, make sure there is no neck emphysema, because
Yeah.
that is the only place that can cause trouble, because your rib cage protects the lung and there is no compression on the lungs. But if your this the cervical or neck emphysema, it can cause compression on the airway, and it's a
Airways.
sedated patient. With a sedated patient, it becomes difficult sometimes. So you have to probably ventilate this patient for a longer time. So
Longer
always
time.
before extubating, check for neck
Neck.
emphysema. Then one thing that we use generally for ERAS also is that we use the cocktails, lignocaine, paracetamol, and that has been very helpful for analgesia as well as reducing the sudden increase in the cardiac while intubation, tachycardia. It prevents tachycardia. Uh, Prehydration before the surgery, because IVC pressure is around 5 to 8 or 10 in a normal person. If there is not hydrated, there is sudden collapse, and then you have more cardiac events like hypovolemia. Because of hypovolemia, hypotension and other things. So prehydration is necessary. The other concern was a tamponade, CO2 tamponade for lungs. Okay, when you're doing Nissan's fundoplication or any other surgeries. So the culprit is a small defect that has been a small rent in the pleura
Diaphragm
that has been
Yes.
either it's
Pleura.
unlikely a diaphragm, but it's mostly the pleura when you're
Pleura.
doing the lateral dissection
Yeah.
in the posterior mediastinum. So it's always a good idea to just open up the defects in a larger size. Just make it larger so that the air flows across very easily. If you have a small defect, it acts as the flap. So
Yeah.
air enters, but it cannot return back.
Return
So if
back.
you have a larger defect, you don't even probably need to put an ICD. Very rarely you need to put an ICD after doing a Nissan fundoplication and other things. So we usually do bariatrics, but for bariatric, we always put a ramp position.
Yeah.
So your sternal notch and the ear
Air
should be
is
in
in
the
one plane.
yeah. So that should be maintained. Post-operatively, we generally make sure that the patient receives CPAP.
Yeah.
Because of hypercarbia and sleep apnea. Then video laryngoscopy is always kept ready.
Must. Yeah.
And one of the other responsibilities of an anesthetist during a bariatric is the management of a bougie.
Yeah.
So
What
there
would
are incidences when the bougie has caused trauma either to the during the surgery or which has been realized later
Later
can
on,
cause a esophageal injury.
Yes.
What we suggest is that we put the bougie right away. We don't put the rice tube to decompress the stomach, but immediately before we insufflate the ET balloon. Before we insufflate the ET balloon, we put the bougie and we put it inside the stomach. And once
Yeah.
we go inside for bariatric, we first see where the bougie is located.
Is going. Yeah.
And so that, and then we just manipulate it in the later half of the surgery.
Yes.
So these
It
were
should
the
be near
few.
the cross foot. Yeah. What we see.
No, that depends what procedure you are doing.
Yeah. Yeah.
Mostly our cases are ruined by gastric bypass, but
Yeah.
it decompresses the stomach as well as you are assured that the bougie is in the right
Is in
plane,
proper
because sometimes
place. Yeah.
for ruined by gastric bypass you are not aware. Later it becomes difficult to manipulate the bougie. So that were few bits from my side. Yeah, and otherwise it was excellently covered, madam. Congratulations.
Thank you. Thank you, sir.
Thank you, sir.
Thank
Yes,
you.
Now I request.
thank you very much, sir. We are
Now I
talking.
request.
You are talking much about anesthesia. Who is your anesthetist?
Who is?
Thank you very much. Thank you
Okay,
very
thank
much, sir. Now I request Dr. Naresh Paliwal, sir, to proceed for his deliberation.
Sheetal madam and Avinash sir will take the questions later, right?
Yes, definitely.
Is my screen visible?
Yes, sir. Yes, sir.
Yes, sir.
Hello. Good evening, everyone. And I'm very much thankful to SAMS, especially Dr. Avinash, Dr. Sheetal, Dr. Shilpa, for providing me this opportunity. My topic for presentation is a little bit controversial, but a comfort shift moving from systemic to regional in the laparoscopic route. Actually, it is well documented in the literature, use of regional anesthesia for laparoscopic surgeries because of the few advantages like few post-operative complications, better pain control, and less post-op nausea vomiting. But today I will be talking mainly about the use of thoracic segmental spinal anesthesia, which has some added advantages of less hemodynamic fluctuations, early recovery, mobilization, voiding, and better like ERAs or ERA protocol, what I call is early recovery after anesthesia. Now, why shift? Understanding the benefits of regional anesthesia. Transitioning into regional anesthesia enhances patient comfort and recovery, reducing opioid use, minimizing complications, ultimately leading to improved surgical outcomes and satisfaction. Now, before proceeding to the main topic, this was a slide which I used for gasless presentation during my presentation in Philippines, just to show the environmental footprints of general versus regional anesthesia. This is out of the way, but just to have a pictorial depiction of what the gases can cause and what regional anesthesia is. This general anesthetic agents can have greater impact on the ozone layer and can create a lot of gas impact. This is CO2 equivalent of 1 Mach hour of common anesthetic gases in kilometers driven. This is a comparison. Test clearance is the most impactful in that case. Nitrous oxide is second, ISO, and CO has the least. Even the RRR approach mentions the use of regional anesthesia whenever possible. Laparoscopic surgery systemic effects. This is all is covered in the previous lecture by Dr. Madam. I will not go into detail. Laparoscopic surgery, GA versus regional anesthesia. Traditionally, general anesthesia has been mentioned as the gold standard, and it is the gold standard for laparoscopic surgeries. And the fear of using regional anesthesia is most of the time because of the requirement of higher sensory levels of block, consequent hemodynamic fluctuations, respiratory discomfort, shoulder pain due to pneumoperitoneum, and raised intra-abdominal pressure. But the ideal anesthetic technique for laparoscopic surgery should have stable cardiovascular and respiratory functions, rapid post-operative recovery, no post-op nausea vomiting, and good post-operative pain relief. The feasibility of laparoscopic surgeries under regional anesthesia. Laparoscopic surgeries under regional anesthesia, spinal epidural, is feasible, safe, and often advantageous to general anesthesia in patients with some high-risk comorbidities like some respiratory issues or other high-risk patients. We need to have some technical considerations before moving on to this regional anesthesia. Like we need to know the anesthetic technique, pressure management, and patient suitability for that particular technique. And we should always have a backup plan to deal with the inadequate or failure of regional anesthesia technique. The key benefits of regional anesthesia, it is opioid reduction. Regional anesthesia significantly decreases opioid consumption, minimizing side effects, and enhancing the patient safety during recovery. It has a faster recovery. Enhanced recovery times are observed, enabling patients to mobilize sooner and return to normal activities. Pain control, patients experience improved post-operative pain management, leading to better comfort. Fewer complications, respiratory and cardiovascular complications are minimal after regional anesthesia if it is properly done, and less PONV. Now, coming to my main topic, rationale for using thoracic segmental spinal anesthesia instead of the routine lumbar or other epidural anesthesia. The main rationale of using thoracic segmental spinal anesthesia is to avoid the physiological drawbacks, potential complications of general anesthesia, and the gross hemodynamic changes, delayed recovery, ambulation, and voiding associated with the routine lumbar spine. Now, TSSA can avoid airway manipulations, improve hemodynamic stability, suppress stress response, reduce incidence of PONV, better pain control, and better patient post-operative outcomes, can have faster recovery and discharge. I'll be showing mainly some video clips after a short presentation on thoracic segmental spinal anesthesia. The prerequisites for doing it under segmental spinal. We should have an experienced anesthesiologist who knows all the details about the technique, what are the and should have the adequate resources, adequate backup plan, and the knowledge about the drug dose, site, and mode of segmental spinal to be used in a particular patient, and also efficient surgeon. Efficient surgeon means you should know beforehand how much time the surgeon is going to take for that particular surgery. I have seen few surgeons doing lap poly within 15-20 minutes, few taking 1 hour, few taking 2 hours. So you have to choose the mode of spinal, drug dose, and few according to your surgeon. And also you should know how adaptable the surgeon is to the change conditions provided by regional anesthesia. Is he accustomed to doing it in regional? A few neurosurgeons I have seen, they are not very reluctant to do it under regionally. The simple appendicectomy, they ask for general anesthesia. Then how flexible your surgeon is. Is he going to listen to your request that keep the initial IIP and initial insufflation rate minimum? If your surgeon is not very flexible, very adamant, no point in going for segmental spine. How cooperative your patient is, willing for sole regional. You should consult the patient beforehand. If he is willing for sole regional, then you should go ahead with this. Otherwise, GA is always the gold standard. We should always have a backup plan to deal with anticipated or unanticipated airway and hemodynamic issues. Now, indications, special indications. Nowadays, we are doing all our laparoscopic surgeries under regional, but it is still not in the standard textbooks to have a to save from the medical issues. There are some special indications, high risk of general anesthesia for either open or laparoscopic surgeries. These are older frail patients, patients with chronic respiratory diseases. These are the special indications like COPD, asthma, interstitial lung disease, patients with associated comorbid conditions or severe systemic diseases for some specific surgeries. Also, many times the patient, they don't want to get general anesthesia and they want to remain awake. In those patients also, this can be a patient preference. The patient selection is always crucial. There are some safety concerns when we talk about segmental spinal. Can there be neurologic injury when we give spinal admit to lower thoracic before the cord ends? It has been proven by MRI. I will show a short video of that. There is sufficient distance from the posterior dura and the spinal cord admit to lower thoracic levels, and the distance is not always there in the cervical and the upper area. Can there be a ventilatory impairment when you give high thoracic block involving the upper abdominal or intercostal muscles? But because of the low doses of isoviric drugs, it is mostly a sensory block. So patient's respiration and cupping ability is usually maintained. Can there be a bradycardia and hypotension because of the higher levels of block involving the cardiosphere fibers T1 to T4? But because of the lumbosacral sparing, the right atrial filling is usually maintained, and that sustains the outflow from intrinsic frontopic receptors located in right atrium great veins, and usually there is no bradycardia. Because of the less sympathetic block, there is usually less of hypotension. Medical issues. Now there is enough evidence to prove its utility in cases where it is most indicated. Otherwise, we can keep our fingers crossed. This is a real-time MRI of adult thoracic spine. Here you can see there is sufficient distance between the posterior. This is CSF and this is the spinal cord. At thoracic level, there is sufficient distance. When you go lower down, the distance decreases. At lumbar level, there is hardly any distance between the posterior. At lumbar level, you can see here also, the distance is measured at various levels. Similar thing was done in a 6-year-old child. This is also a real-time MRI. I have a publication on pediatric segmental spinal also. We had a lot of cases of pediatric spinal. Here also you can see there is sufficient distance between the posterior dura and the spinal cord. This is thoracic level. When you go down, the distance goes on decreasing. This is also measured at various levels. Now coming to different modes of segmental spinal. It's not just like giving a single shot spinal. It can be a single shot spinal for short duration surgeries of 90 to 120 minutes, or it can be combined with epidural for long duration surgeries, or in a very high risk patient when we want to use a very low dose in segmental spinal. Here, the epidural can act not only as a backup, but by epidural volume extension, it can spread the low dose used intrathecally to wider segments. And the third option is continuous segmental spinal anesthesia. This can be an option when you get accidental dural puncture in epidurals, or it can be used primarily in a very, very high-risk patients. This is actually continuous similar to continuous spinal anesthesia, which has been mentioned in the standard textbooks also for very high-risk patients. Now, segmental spinal for laparoscopic surgeries, drugs and additives. Generally, isobaric drugs like bupivacaine, levobupivacaine, ropivacaine, or chlorprocaine. Chlorprocaine was a very good drug, but recently it's not available. But it was a very good drug for short duration surgeries. It's preferred over the hyperbaric for laparoscopic surgeries because it is not position dependent. These are very good drugs. Additives which will not cause post-op nausea, vomiting, and respiratory depression are usually preferred, and also which will not cause urinary retention like morphine. So additives like fentanyl for short duration surgeries and dexmedetomidine is the best sinus additive. It can prolong the duration in a dose-dependent manner. Also, the side effects are in a dose-dependent manner. So this is the best additive. Ketamine can be used at times. It can prolong the sensory block, but it can shorten the motor block time. Clonidine can be used when dexmedetomidine is not available. These are the available isobaric drugs: isobaric bupivacaine 4 ml, isobaric ropivacaine 4 ml. These are all etiosterile ampoules, and isobaric levobupivacaine 4 ml ampoules. If these ampoules are not available, we have used even from the isobaric levobupivacaine vials at times, single drug, single use from a single vial. The advantages of isobaric drugs are less sensitive to position issues. In low doses, they have preferential sensory block named as selective anesthesia. It has a propensity to block selective sensory block as compared to motor block. Onset is gradual. There can be hemodynamic stability, early emulation and voiding. Spinal can be given direct before epidural. Whenever you use spinal and epidural with different needles, what you do is you always put an epidural first and then spinal, because you don't want a saddle or a unilateral block with hyperbaric drugs. Here, you can use spinal before epidural and at a level higher than epidural. The disadvantage of isobaric drugs are levels of block cannot be modified by exchange of positions. Once you need to calculate beforehand what amount of drug and what site of injection you have to use for that particular surgery, because you cannot adjust the levels after giving the spinal, just like your hyperbaric drugs by any change in position. There can be sacral sparing when low doses at higher or low thoracic spaces are used. This can be an advantage for upper abdominal surgeries, but can be disadvantage for some surgeries like TLH or PCNL, where you need to have some dense block at sacral roots. So either higher doses can be used or drug combination. I'll be coming to that later. It has some longer onset time than your hyperbaric drugs, especially when used at a lumbar level. It has some slightly less muscle relaxation, but isobaric bupivacaine nowadays, which is introduced, it provides a very good relaxation even in muscular patients. Otherwise, hyperbaric drugs can be choice for open surgeries instead of these isobaric drugs. These are sensitive to temperature variations. It can become slightly hypobaric when warmed at 37 degrees. It can become hyperbaric when cooled at 24 degrees. So these temperature variations do matter when using isobaric drugs. Dose and the site of injection. Dose depends on the type, site of surgery, duration, and patient characteristics. You can modify everything according to your need. Goal for laparoscopic surgeries is to achieve levels below T2, T3 at least. Dose around 1.5 to 2 ml with some additive at around T10 works nicely for around 90 minutes. If you use Dexmed, it works even for 2-3 hours. Dose can be individualized as per need of surgery, patient, surgeon, and mode of segmental spinal. If you are combining epidural, you can use low doses. If you are using Dexmed, it can prolong duration very nicely. So everything can be modified. Coming to two drug techniques, hyperbaric with isobaric, just like I told before, that for abdominal pelvic surgeries, what happens if you use low doses of isobaric drugs at low thoracic levels? The lumbosacral roots may get spared, or even if they get involved, the effect starts varying from below upwards. So for surgeries involving pelvic manipulations, what you can do is just 0.3 to 0.5 ml of hyperbaric first, followed by 1.5 to 2 ml of isobaric drug at around T10. That works nicely when given in sitting position in different syringes. The other combination is hypobaric with isobaric. This is useful for surgeries of upper abdomen, especially laparoscopic cholecystectomy. When patient is kept in a head-up position, you can take advantage of that position. We can use just 0.1% of around 2 ml of the hypobaric drug first, and then 1.2, 1.5 ml of isobaric according to need. So when the patient is in the head-up position, the hypobaric drug will go up and prevent the shoulder tip pain. We'll have adequate sensory levels. Monitoring sedation and analgesia. Basic monitoring, apart from NIBP, SpO2, ECG, ETCO2 is mandatory, and other invasive monitoring as per the comorbidities of the patient. For sedation, the combination of dexmedetomidine and ketamine is ideal for sedation. I was little surprised when dexmedetomidine was not mentioned during general anesthesia in the presentation. This is the all-in-one drug, which is very useful, especially for OSA patients and other patients. The combination of dexmedetomidine and ketamine that maintains the airway very nicely. The airway tone and reflexes are well maintained. So it is the ideal sedation what we use for sedation during our cerebral spinal. And multimodal analgesia, drugs which will not cause post-op nausea, vomiting, respiratory depression, retention of urine, and delayed recovery are preferred in the form of dexamethasone, diclofenac, and paracetamol. And local anesthesia at the port site is what is our protocol routine. Use of ABG monitoring, not mandatory in healthy patients, and short duration surgeries without complications. Just the surrogate markers, your ETCO2 monitoring and NIBP. This can help. Just close observation, non-invasive monitoring. Enough. But indications for ABG monitoring is pre-existing severe cardiopulmonary diseases, OSA patients, obese patients with comorbidities, prolonged procedures, especially this total extraperitoneal or retroperitoneal procedures, which leads to very high absorption of CO2. So in those cases, if they are very prolonged procedures, then ABG monitoring can be very helpful. Adverse symptoms and signs pointing towards acidosis and alkalosis. If there are adverse signs during any time, you can do ABG monitoring. And in pregnant patients to avoid the fetal acidosis. This can be helpful. Now a short comparison between the segmental spinal and segmental epidural. Both are really the same. The similarities is both produce a segmental block with minimal hemodynamic changes. Injection site is most important. Should be in the middle of the dermatomes required for that particular surgery. Concentration of the drug affects the density of block in both. Lower the concentration, more the selective will be the block. Then there are some positives about segmental spinal. It's economic, quick, with a definite endpoint in the form of pre-flow of CSF. There is early onset, uniform dense block with minimal drug. Just 1/10 of what we require for segmental epidural. You need just 1/10 of that. So the chances of loss are negligible. There is good relaxation required and oxidation is less. And also the failure rate is low, even in cases of previous spine surgeries or deformities. The only thing is there is no versatility to extend the level or duration of block, which is present in epidurals. Now I'll show some short videos just to show how simple it is at the low thoracic level. This is 27 gauge needle in the lateral position. And this is a mid-thoracic level. This is actually for breast surgery, what we use at thoracic levels. But the midline approach is not useful at mid-thoracic levels because of the angulation of the spinous processes. So here the paramedian approach, just by the most prominent part of the spinous process, what we do is hit the mid-lamini, then upward inward angulation to enter the interlaminar space. And this first one was the midline approach. Both are done with the 27 gauge needle. Now I'll show some videos of some particular patients which are done. This is 70 years old, obese, diabetic, hypertensive, ISD, CVE 4 years back. He was having chronic atrial fibrillation for lap cholecystectomy. Here the segmental spinal with 1.6 ml of isobaric bupivacaine with 25 micrograms of fentanyl at T1112. You can see here the patient during surgery. He was an obese patient. He was having atrial fibrillation. It's comfortable during surgery, and just after 3.5 hours, she is moving. This is 70 years hypertension, IIT, old infarct, PTCA, laparoscopic cholecystectomy. Again, 1.8 ml of bupivacaine plus 20 micrograms of fentanyl at T1011. Many surgeons, they complain about the big movements during this, but if the level of block is adequate, there is not much of movement. The patient is sitting comfortably immediately after shifting. This is the lap-assisted open right hemicolectomy. A morbid frail female with chronic cough. This was done because it was a lock procedure. It was combined with epidural. Epidural was put at T1011 and spinal was given 1 level below with 2 ml of isobaric bupivacaine and 10 micrograms of Dexmit. The surgical duration was 3.5 hours. Epidural top-up was needed only after 3 hours. This was the whole dissection of the right colonic area was done laparoscopically. Then with a small incision, the colon was taken out. Resection anastomosis was done. The same patient moving comfortably in the evening. This is 70 years old female with scoliotic and fused spine for laparoscopic assisted vaginal hysterectomy. This was yesterday's patient only, 1.8 ml of isobaric bupivacaine because she was having a scoliotic spine. A paraspinous approach was used with a 27 gauge needle. She had a scoliotic curve. And she is comfortable immediately after operation and she was moving within 4 hours. 72 years, diabetic, hypertension, PTCA, 3 stents, ileojejunal foreign body was there. There was a thick foreign body at the ileojejunal junction, and it was done lap-assisted open surgery. First, laparoscopically, the foreign body was located. The foreign body was located, then with a small incision, it was taken out. And this was a big stone-like foreign body which was there. It was removed, then resection anastomosis was done. And you can see the patient shifting herself at the end of surgery comfortably. This is 43 years female, recently diagnosed diabetes. This was yesterday's case, hydrated cyst of liver. It was very difficult to locate that hydrated cyst. Actually, it was in the segment 7 on the inferior surface. These are the segments of liver. It was in the segment 7, post inferior surface of that segment. It took a lot of time to locate that cyst because there was no indication of it being there on the surface. It was the inferior surface of the liver. It was removed. This is the camera inside the cavity. There's a big cavity, almost 10 centimeters. Is the patient comfortable during surgery? The same patient shifting at the end of surgery. Surgery was around 90 minutes duration. 89 years old, diabetic, IgT, kyphoscoliotic, basal atelectasis, SpO2 92, platelets 87, empyema gallbladder for lab poly. It was done with bupivacaine plus fentanyl. Patient again shifting herself and mobile with 3.5 hours after surgery. Lab poly, 62 years female, diabetic, hypertension. Here hypobaric bupivacaine was used. This is what I was talking about, 2-drug technique. First hypobaric, this is done by recipient. 0.1% 2 ml was given first, followed by 1.5 ml of isobaric bupivacaine, 20 micrograms of fentanyl in different syringes. The levels being tested, she had no sensation at C8, little finger, but her grip strength was good. indicating only a sensory block. The same patient, at the end of surgery, she is comfortably moving her legs and ready to shift. Acute ruptured ectopic, I must have done more than 40-50 cases of ruptured ectopic. It's just a short review. This was done under chlorprocaine. But the only thing with chlorprocaine was you always need a preemptive analgesia before the effect is weared off. The effect wears off very suddenly with chlorprocaine. This is TLH. This was a patient who was a relative of an anesthesiologist from Mumbai. She was having atlantic cell distribution with bacillary invagination, diffuse disc bulges at C5-6, C1, C2 fixation with limited mouth opening and neck mobility. There was partial neurological weakness at right upper extremity, tingling sensation over shoulder and scapula. I consulted the anesthesiologist, and this patient was very much worried about her neck movements. She used to get this nausea and this thing with neck movements, so she happily agreed for a segmental spinal, and it was done with segmental spinal. This is total laparoscopic hysterectomy with a single drug technique, 45 years, 100 kg patient, hypertensive, previous to seizures, just 2.2 ml of isovaric bupivacaine, plus 10 microgram dextromic, T11-12 level. Duration was around 2.5 hours, and Dexcat was used as a sedation. This is obese patient with hyperthyroidism for TLH. I was, little dilemma whether to use general anesthesia for this patient or give segmental spinal, because on table the patient had a pulse rate of around 170 or 160, but slowly it settled down, and patient gave a history of slight cough since last night. So I convinced the patient, and she was given segmental spinal. Advanced nasopharyngeal airway was put for ETCO2 monitoring. This is ECNAV, which is put for oxygen supplement and monitoring of PTCO2. I can see the smiling patient at the end of surgery, and she is thanking us for. She was thanking the surgeon only, so I asked her, "Why not thank me?" So she was smiling, and the same patient sitting comfortably and having tea, coffee. 18 years old female, sickle cell disease, history of multiple transfusions, mild fever, icterus, dry cough, or lap coli. This was again done with segmental spinal. Same patient at the end of surgery. This is 8 years old. I have done more than 3-4 cases of sickle cell anemia and segmental spinal. All small kids, 6 years, 8 years. This is the same patient at the end of surgery. 13 years, 34 kg bicoordinate uterus with rudimentary right cornu. Surgical duration was more than 130 minutes. The hysteroscopic confirmation was done at the end of surgery. This is 40 years female, 102 kg, hypertension for lap coli, and small umbilical hernia was also there. This is an obese patient. You can see the patient talking comfortably during the surgery. These are the different monitoring. This was a big gallbladder which was removed, and she also had umbilical hernia which was repaired. The same patient at the end of surgery, she is shifting herself and moving comfortably within 4 hours. 40 years female, cholelithiasis and pyelonephritis. Her count was deranged. She had central obesity, deranged electrolytes, low platelets, around 87,000 or around 1 lakh. This is during surgery. Same patient, just after 4 hours going to washroom. don't put any urinary catheters for such type of patient. This was a special patient, unanticipated airway. He was intubated with difficulty because the resident called me. I intubated the patient, then came back to my case again. By the time I came back to my case again, the resident thought that tube is not inside, and accidentally he was extubated. And then again, when we tried to intubate, there was a lot of blood and everything. So surgeon postponed the patient. And next time, after 3 weeks, when this came again for surgery, I convinced him for segmental. And now he's watching his own surgery. This is an 80-year-old perforated appendix with upper respiratory tract infection.
So I can disturb करूँ चु.
Even
अच्छा
the
मेरी
kids are
wife ने
comfortable.
Hello.
12-year female twisted ovarian cyst.
शुक्रवारे अहमदाबाद. Hello. मेरी wife ने शुक्रवारे अहमदाबाद जવું પડે.
Patient shifting herself.
કાલે ભાવે કરવા માટે.
This is actually not part of this presentation, but I have done few cases of non-intubated video assisted thoracoscopic surgeries also. Very complicated patients. When capnothorax is not used, we do this under segmental spinal. Thoracoscopy and pleurodesis.
Request available to both time.
These are my all publications. Even more than that, this was the book which I have published in 2023. And thank you very much for patient listening.
Yes.
I will be happy to answer questions. Thank you.
Thank you very much, sir. Excellent deliberation with full of practical tips.
An
So I
excellent collection of
request
cases also.
Yesterday only I did 5 cases. 2 lab police, 1 headache, 1. And tomorrow I have a list of 3-4 cases. So it's now routine for me.
So I am a surgeon, so I have only one concern. So this is my anesthetist has been behind me to try segmental anesthesia. I have done 2 cases, fundoplication where airway was there was asthma and other issues, respiratory issues. So we proceeded with segmental anesthesia. They went on very well, except for one patient who kept on moving his leg continuously throughout the surgeries and removing his drips. So that was one of the issues. But otherwise, I was extremely happy. But the only thing I'm concerned about is the legal protection in a healthy patient, wherein you are doing a segmental anesthesia for lap chole and when other safer techniques are available. So that is my only concern,
that's
and
what
I'm
we
stopping my
always
anesthetist.
recommend. Sir, that's what we always recommend in all our, almost every 15 days I am doing a workshop or presentation. So we always recommend to do it in a case where it is most indicated, so that you are medically safe. Now there is enough evidence to prove its utility in cases where it is most indicated. Those who are comfortable, those who can convince the patient, they can do it in the routine cases. But for beginners, we always recommend that it should be done only in cases where it is most recommended. The cases, high-risk patients having some pulmonary issues. So even if it is done in such cases, it can be a great asset to have in one's armamentarium. It can be useful.
I agree, sir.
Hello.
I agree
Excellent
with that,
depiction
but
of
only
your work.
thing is legal protection.
Yeah.
Yes, legal protection, that is I already described in my presentation. We can keep our fingers crossed. But now it is coming forward. Now the criticism is not as much as it was during my initial presentations during 2010-11. I started presenting these right from early 2000 actually. But there was a lot of criticism. Now the acceptance is such that every month I am in some these workshops or presentations at different places. Slowly it is getting lessened.
Hello, sir. May I ask question?
Yes, sir.
Yes, sir. Sir, is it in Maharashtra, is it legally allowed to give spinal anesthesia, regional anesthesia for laparoscopic surgery? One of our conferences in Coimbatore at Dr. Palani Veluru's hospital, one of the senior anesthesiologists repeatedly said laparoscopic surgery, general anesthesia. and he asked audience to repeat laparoscopy surgery, then we used to say general anesthesia. It is to that extent he was determined to say ki laparoscopy surgery only general anesthesia. So that is one thing. And second is it allowed in Maharashtra legally to give regional anesthesia for laparoscopic surgery?
No, it's not like that. It's not allowed. Even lumbar spinal, there are almost everywhere in Maharashtra, the private practitioners are doing under lumbar spinal most of the cases. This is just for the reason of economy most of the times, not for the indications. But these are well documented. Lumbar spinal, epidural, and other things. The segmental spinal is yet to get approved, but it is better than
There
what
is a
we
lot
can.
of literature that has been published with regional anesthesia. So probably you are well protected if you are doing surgery under spinal anesthesia. So and actually the real game changer for regional anesthesia came in 2000 after the COVID, because after
Yes,
the COVID
it
the
was
people were
well
afraid of
accepted in
giving.
COVID.
Yeah, so acceptance and it became rampantly accepted only after COVID.
The only
And
thing
started
which
doing
was beneficial.
Laparoscopic, can I say?
Yeah.
Laparoscopic surgery under spinal anesthesia is an acceptable norm. What we
Yes.
are a little worried about is the thoracic segmental spinal, where there is chances that you can injure or can cause harm to the spinal cord. So, have you done any comparative study where you have
Yes, there
given
are
the
many
lumbar
RCTs going
segment,
on, many publications.
regular spinal against the thoracic? Means
Yes,
why
madam.
not give the lumbar epidural anesthesia, I mean spinal anesthesia?
You see, what happens, even if you use 4 ml of the drug at lumbar spinal, you may not achieve the adequate levels. There is a lot of hemodynamic fluctuations with the dose you have used. There is no lumbosacral sparing. I mean, the hemodynamic fluctuations
In your practice, have you noticed any, injury to the spinal cord or during giving?
Not yet, madam. Because two things I would like to mention. There are even trainees who are giving thoracic epidurals. And there is accidental neural puncture with a very large needle. And there is very less neurological issues just because there is sufficient space between the posterior and the spinal cord at this level. If the thoracic epidurals can be justified with such a big needle, why not with a very carefully performed spinal anesthesia? This is one thing. And second is, actually, there are a lot of publications now to justify its use. The dose we are using as compared to lumbar is just half the dose. There is early recovery. As you are seeing the patients moving from table to stretcher on their own, they are mobile within 2-3 years. We don't put a urinary catheter even for such surgeries. They are ambulating. They are going to bathroom within 3 years. So there are many things which are avoided.
Yes, I am using lumbar spinal anesthesia for laparoscopy surgery since 2003. Almost 22 years.
Before that, I used to use lumbar spinal only. But the problem is you need quite high doses. And patient is not recovery is not as good as this spinal. The hemodynamic changes are more. The patient needs some sedation because of the thing. And hyperbaric drugs, they tend to go upwards when you give a steep head down tilt. This is one thing which can happen with hyperbaric drugs. But with the isobaric drugs you can give any position and without fearing for high levels or total spinal. These are
do you recommend any image guidance while doing the first
image
few
guidance
pieces?
Yesterday only I did a case at our institute, a very high risk patient which was postponed for 3-4 times. It was not a laparoscopic surgery. That was just jejunostomy, gastrostomy for esophageal mass. He was having asthma. He was having severe aortic stenosis. And also previously operated incisional hernia was there. I have that videos also of that patient, but it was not a laparoscopic surgery. I did not include that. I did a USG guided spinal. So you can always use a ultrasound for better quality. I did a USG guided spinal at T8-9. Just use 0.8 ml of the drug. The levels was from T4 to T10 only. And then surgeon said to me that initially he was saying we will do it under local, but it was not feasible because everything, there was no rectus muscle because of the previous surgery, and also he had hernia. If I can show you the video, if you permit me, I'll show the video of that patient also. Just on Monday only I did that case. So you can always use the image guidance for better safety.
Avinash sir and Sheetal madam, can we meantime have the, I'm sorry.
Yeah.
You can take
About the
questions.
legal consideration, sir, even all additives what we use in for spinal or segmental spinal are not FDA approved. So
No, there are a lot of publications, and you can always use
even
off-label use
with
of
the
these drugs is
publication,
recommended.
yeah.
Even in USA, when I went there, they are also using off-label drugs. Exmit. I talked to the surgeons there.
Yeah, so a few questions to Vaishali madam, quick questions. Is madam there?
Yes, I'm
Hello.
there.
Yeah. Madam, first question was whether any preference for laparoscopy regarding sevoflurane, isoflurane, and desflurane.
It depends upon which kind of patients we are doing. But Sevo is now available, I think, almost at every place. So I prefer sevoflurane in routine cases. And for bariatric cases or obese surgeries, I prefer desflurane. With isoflurane, I feel the recovery is comparatively delayed.
Okay. Now, two people have asked whether one has asked that whether ketorolac is actually necessary, and second madam has asked whether diclofenac can be used because they routinely use diclofenac.
Yes,
Which you
ketorolac.
would prefer?
Diclofenac is available everywhere. It is not mandatory or not necessary that ketorolac should be given. But whenever given, if IV we give in a dose of 0.5 to 0.6 milligram per kg, the breakthrough pain relief is very fast.
So one single dose of ketorolac 0.5 to 0.6 milligram per kg.
Yeah, yes.
So you have noticed that the breakthrough pain is less.
Yeah.
And any experience with diclofenac?
Diclofenac also it's being routinely used in a post-operative period in our institute. Yeah.
Okay.
Can I
Yes.
ask one question, Shilpa madam?
Yes, madam.
Yes,
Yes,
Kanchi madam, good evening.
Good evening, madam. Both the presentations were excellent.
All others are requested to mute their microphone. All other. Okay. Yes.
Sir, madam, one question, Vaishali madam. Have you come across emergence after using sevoflurane?
It was experienced in a longer case of colorectal surgery, which lasted for almost 7 to 8 hours. And after that, emergence delirium type of picture was noted. So there are few cases in which emergence is noted with sevoflurane also.
How did you treat it, madam?
Actually, we had given Serenus to that patient.
Because we are seeing a lot of the patients post sevoflurane over long period of time. They become more rowdy and irritable in the post-operative period. Whereas patients on isoflurane, they are more stable and calm and quiet in the post-operative period.
Because I feel because isoflurane, there is a slight sedation. And with sevoflurane, and along with that, if pain is there, then those patients becomes more rowdy. So if analgesia is given very well, then probably the incidence of hallucinations or maybe emergence from sevoflurane would be less.
Okay, can I take the next question? It is about
the...
Yeah, thank you, madam. About the ventilatory settings, I think you already said.
Yeah.
Yeah.
Ventilatory setting, I prefer 6 ml per kg of tidal volume, average 16 respiratory rate, maybe if everything is settled, I can go for 12 to 14 also. But with 16 RR, the EtCO2 is maintained very well.
Do you prefer PEEP, madam?
Not in every patient, but in slightly obese patient, I prefer PEEP intermittently, not a continuous PEEP.
Okay, around
If
4
recru-
centimeters.
Yeah, if recruitment can be given, there is no need of continuous PEEP.
Another question is regarding interfacial block. I think Amla madam already talked about oblique subcostal. You have any suggestions?
Yeah, we do.
Interfacial block.
We do lower intercostal block. Interfacial, I don't have any experience with that. I am not practicing that. I usually practice either 4-quadrant block or in lower intercostal block.
Okay, lower intercostal.
Yeah.
Okay. And not the rector sheet block for the main
Rector
ports?
sheet block, yeah, we can give.
Someone has asked whether dexmedetomidine decreases the dose of inhalation agent.
To some extent. Because sometimes we tend to give more inhalational agent to achieve hemodynamic stability. So if dexmedetomidine is given, the hemodynamic stability is also maintained. So with lower MAC, we can do the case.
Okay, and the last question is whether sevoflurane is safe in pregnancy.
Yeah.
It's safe. Now, thank you so much, madam. Few questions. Avinash sir and Sheetal madam, can I ask you, Paliwal sir?
Yes.
Yeah, Paliwal sir.
Yeah.
Can I start? Yeah.
Before that,
Duration of-
can I ask one
Are you
question
able to
Vaishali
share
madam?
the video? Is it ready?
Okay, you want to see that video? I'll just.
Avinash sir, काय करूया?
Just sir is showing video, no?
हो. मग question घेते.
Yeah.
I'll just look where actually. By that time, we can continue this discussion. Actually, I'm just searching for the.
Okay.
Because
So,
it was not in my question.
One question is whether how much is the duration of action of levoanavin?
If it is used without any additive, it is just around 70 to 90 minutes.
It's around 90 minutes. And is
with
lateral
fentanyl,
position...
it is 90 to 120 minutes. And if you use with dexmed in the range of around 10 micrograms, then it can prolong up to 3 years with just 10 milligrams of the levoanavin. But
Okay.
can be prolonged up to 3 years.
Yeah, that's really good. So is lateral position better always than the sitting position to give the segmental?
And when you are using isobaric,
most of the people are using this sitting position only. But
you prefer lateral?
I prefer lateral because the patient is more comfortable. What I always say is patient is always comfortable in lateral position and anesthetist is more comfortable in sitting position. And the chances of PDPH are very less, especially if you are using very fine gauge needle. We mobilize our patient within 2-3 hours and hardly any PDPH, just 0.001% rate.
Okay. Dr. Avinash sir was saying something.
No, the same question I was asking. If you are using isobaric, then which position you are preferred?
With isobaric, the advantage is you can use any position. The isobaric drugs are little on the verge of being hypobaric.
Yeah.
And if you use a sitting position along with fentanyl, then it becomes slightly hypobaric. The chances are there, if you keep the patient seated for some time, there can be higher levels of block. Yesterday, I did a large hemangioma on a 8-year-old child, adding fentanyl to this hypobaric drug. The hemangioma was on a iliac crest. I used a unilateral hypobaric spinal for that. Because the patient was in lateral position, just use 0.8 ml of isobaric levobuprofen and 0.2 ml fentanyl. Patient spinal was given with operative side up, and kept in same position. Actually, I'm not able to share those videos. I have all those
So
videos.
why hypobaric in for iliac spine?
No, it was over the iliac crest. There was a large hemangioma.
पण मग साधं रुटीन हायपर
Iliac
किंवा
crest.
आयसोबॅरिक का नाही?
Then
Why
what,
hypo?
when giving hyperbaric, you can give unilateral spinal, but for that you need to change the positions frequently. First, you have to keep the operative side down, give spinal, wait for some time, then change the position with operative side up. Here, the advantage is you keep the patient directly in the operative position, give spinal and start.
Okay.
Okay.
And
Shilpa, it's now 9 o'clock.
Okay.
Last question, if anything remain or anybody can
मी
ask
सगळे
the last
क्वेश्चन वाचून
question.
दाखवते. How much
I'll
abdominal
share
pressure?
those videos on Sam's this thing,
Okay.
Yeah.
WhatsApp group.
Okay.
How much abdominal pressure do you advise in segmental spinal? Does each case require sedation? Can we do lap nephrectomy under segmental spinal?
Yes.
Does spontaneous respiration disturb the surgeon?
Okay.
There are
It's
few
rapid
things
fire.
which
Rapid fire.
we can do
How much
always,
abdominal pressure
all
are you?
abdominal surgeries, upper abdominal, even thoracoabdominal surgeries under segmental spinal.
I'm
We
sorry.
allow our surgeons to have initial IAP around 12 and initial flow rate minimum. Just start with 2 liters and they can increase up to 20 liters afterwards. Once the trocar are in place, then we allow even up to 15-20 liters because then everything, the leak starts. But sudden inflation of abdomen is usually avoided. The initial flow rate we start with 2, then increase slowly because there can be vasovagal bradycardia, hypotension. That can happen even under general anesthesia also. But we allow the pressures up to 10, 12. In children, we allow up to 8, 7, 8. Then they can increase up to 14.
In children, you give
Okay.
after sedation. After TIVA, you give
I
segmental.
use Dexket
Yeah.
as a sedation. Dexket is the best sedation for pediatric patient, even from neonates to
Dexket.
morbidal patients. I have my presentations on Dexket actually.
And in adults, what sedation do you give?
Dexket, just
Dex.
0.5 mcg per kg of Dex and 1
Okay.
milligram per kg of ketamine. Mix it together, dilute it up to 5 ml, and then as required, just 1 ml aliquots. That is
Okay.
enough.
In
The
which
advantage
case?
is the respiratory movements are not disturbed. The one thing I always suggest to everyone that the requirements for doing it under segmental, you should have adequate levels of block. If the adequate levels are not there, and if you are using sedation, which will change the respiratory movements, that can disturb the surgeon. So heavy sedation should be avoided unless you are planning to secure the airway with some supraglottic devices.
Sir, in which cases do we use hypobaric? Sir, last question, Avinash sir. Hypobaric कोणत्या cases मध्ये
Hypobaric,
वापरतात?
there are many advantages for superficial surgeries. We use right from even this NEVAT we have done in hypobaric, even for breast surgery. Depends. Even lower
And
limb
you
surgeries.
dilute with what to make it 1%?
Distilled water. Either dilute with distilled water, and depending on the invasiveness of the surgery, you can choose your concentration, right from 0.1, 0.15 to 0.2, or even just with adding fentanyl, it becomes hypobaric.
Okay, that's
What
it. Thank you.
Yes. What you do when the surgery prolongs before you are going to intubate? Any other trick you use to prolong the anesthesia or prolong the?
It depends. We have to beforehand estimate everything. Talk with the surgeon, what is the likely duration, and choose your mode of segmental spinal accordingly. Like for that hemicolectomy procedure, we used epidural as a backup, or you can use additive, just like we use Dexmet for long duration. So according to your surgery, surgeon, patient, everything, you need to have a pre-operative assessment.
Okay, thank you, sir. Now I request Sheetal to present vote of thanks.
So it's my honor and immense pleasure to propose the customary vote of thanks on this webinar. My sincere gratitude toward both the chairperson for accepting our invitation in spite of their busy schedule, Dr. Amla Kudalkar madam and Dr. Mansi Adnaik sir, and for sharing their vast experience and valuable inputs over this laparoscopic surgery. Then I thank to both our faculty, Dr. Vaishali Shelgaonkar Madam and Naresh Paliwal Sir, for their very informative, practical-oriented, case-oriented, and quiz-free talk. I especially thanks our MMC observer, Dr. Vijay Kanse Sir, for attending today's webinar. Then special appreciation and thanks to the Satara Society of Anesthesia and their president, Dr. Subodh Haware, and secretary, Dr. Amruta Vokil, and Surgical Society of Satara for getting the MMC credit hours today. And thanks to all anesthesiologists and surgeons of various city branches for this huge response for this webinar. It's almost crossing more than 235. So thank you very much.
Thank
very
you.
much.
Thank you
Thank
very
you.
much. Good night, everybody.
Thanks for inviting
Good
me.
Good night.
night, sir.
Good night.
I'll
Thank you.
share those videos on Sam's group.